That's badness in a patient that looks, it's that patient that looks like they're having a STEMI. Oh man, I shouldn't have said that.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Let's get to it, Matt.
All right, so in part one, we talked about this new term, I would say. Again, like we said in part one, the pathophysiology has not changed in heart attacks. Right? But it's not all about STEMIs. And so there's a new catchphrase terms, OMIs, Occlusive Myocardial Infarctions. And so why don't you go ahead and review what we talked about in part one?
So we talked a little bit about, like you said, the pathophysiology is unchanged. Right. We're just wanting to recognize more. If you're only looking for STEMIs, you're missing, up to 25% of this patient population, super sick. Right. So to be at our best, to optimize the care we provide, we've got to be looking for other patterns. And so we wanted to cover those 5 patterns today. Right. And we talked about the first 2. Yep. Is inferior MIs. We talked about how a 2-3 AVF, you're looking for elevation. To meet classic STEMI criteria, you have to have a certain amount of elevation. Right. But what we were saying was any subtle elevation at all in the context of what looks like it could be a STEMI, a sick patient, right? Any occlusion, any elevation at all could indicate an occlusion in that inferior, that right-sided coronary system, and is a pathophysiology of badness, and that's highly suggestive of something that's going to need the cath lab. Yeah. And so if we're only looking for that 1 or more millimeters of elevation in 2-3 AVF, we're going to miss lesions that are highly suggestive of an occlusion of the coronary system.
And it's important to note that its lead placement is very important.
Yep.
Like make sure that your leads are stuck right, your placement is right, the patient's not moving. Because, you're talking about small little changes that if you're off could have those changes. And the reason is that you said this in part one is the tissue size. Yep. The right side is not as muscular as the left side. So you're not going to have as much amplitude as you would in the left side.
Right. Well, we've all seen that tombstoning, right?
Yeah, exactly.
That's pretty impressive. And to do that, to move that much, you got to have a lot of muscle. So, the right side could be hypertrophied too, and it could have more muscle than it's supposed to have.
Yeah. But then that elevation is going to be more prominent. So that's going to be easier to find.
Yep. So we got 2 factors, and we talk about this in our EKG basics. To deflect the EKG leads on that paper, you need muscle with electricity in it, and then so the more muscle you have, the more the deflection. Right. But then you also have to consider the lead. Right. How far away is the lead from the heart, right?
Which is going to come into play later when we talk about another pattern.
I think that's 3 or 4 coming up. Yeah, so that's a huge factor. So we talked about that. That was the
inferior,
first one.
Yep. Any inferior elevation, don't even have to have reciprocal changes.
Yep.
Any inferior elevation should raise a red flag, forward it on, talk to a doctor, go from there.
And again, make sure you're following your protocols.
Of course.
And talk to your medical director, like we talked about. Talk to your FTO, your training division there for EMS.
EMS chief, EMS captain, whoever,
Maybe they need to adjust things. Talk to your hospital systems. Ask these questions. Hey, forward them this podcast. Hey, Dr. Axene and Matt were talking about this thing called an OMI, and I'd never heard of it before, and I learned a lot. Go look at the data. We should put the link up for this.
Is it data or data?
I say data.
You just said data.
Data? Data. I'm so confused. I'm married to a Canadian.
We've had this conversation.
So my wife will
the
say,
data out there.
"Oh, I'm so sorry about that."
She's gonna love that.
I've had a friend. He had a shirt that said "Canada, America's hat." Is what he said.
That's pretty good.
I love my dad's Canadian. Yeah. My wife's Canadian. I've got tons of family up in the Lower Mainland. Oh yeah. So anyway.
All right.
But they say words funny, so that I don't know. Like my wife, we go to the grocery store. It's not produce. I say produce. She says produce. It's not a laboratory. It's a laboratory. It's not a capillary. It's a capillary. There's some weird stuff up there in Canada.
Does she say aluminium?
Yeah.
She does not.
Yeah, she does.
She does.
Well, really? She's been Americanized now, so she says aluminum.
Does she
like
say
the rest
schedule?
of us. Well, she probably would have. Well, see, she grew up with a family from New Zealand too, so a lot of that.
She's all over the map.
Like the spelling, like honor is Honour.
Yeah, right.
I don't know why they kept the U in glamour. but
Yeah,
we lost it with honor.
Lost it with honor.
Anyway, so back to this. So the other one we talked about, the second one.
Yeah,
again,
this one's complicated.
It is, and I think this is the one that I had to review. Honestly, as an ER doc, we had this confessions from an ER
We
doc.
did in part one.
Right.
We double checked that what we were saying was correct. Yep.
So check me on this.
Nothing wrong with that.
Yeah, I'm learning stuff. I love learning things. So your friend here, doctor, is learning new things.
Yes.
I did learn this in medical school, but I didn't understand its significance until
I was going to say the importance of it.
the last few months.
Yeah.
So.
All right, so go ahead.
A bifascicular block. So two parts to the bifascicular block. The easy one is looking for the right bundle.
Right.
So on the right fascicle, we got some blocking of that the right fascicular area, right? That's the right bundle. A right bundle plus a left anterior fascicular block. Right. Now, the left anterior fascicular block, 3 things to look for. Again, pretty simple. I'm trying to make it as simple as I can. Mm-hmm. You need left axis deviation. Yep. We talked about 1 in AVF, right? If they're both up,
yep, good to go.
We're good. Normal axis. If the AVF is down, okay, this is not normal because we want them both up. If one's down, we got to figure out if it's right or left. Yep. So the AVF tells you what it is, right? Left axis. So if it's down, you're pushing the turn signal down, and that turns your car left, right? I mean, if you go the direction.
The car doesn't turn left.
No, you do. Yeah,
you're signaling that you're about to turn left. Some people have that confused.
Now, if AVF is up and 1 is down, now, when you turn it up, you go to the right. Okay, so left anterior fascicular block, AVF will be down, 1 is up. And the other 2 things we look for to define a left anterior fascicular block, in addition to left axis deviation, we want to see QR complexes in 2-3 AVF and QS complexes in yes, or RS, sorry, QR, yeah, and 1 in AVL. Yeah.
No, QS in 1 in AVL. I'm sorry, RS in 1 in AVL. This is super complicated. Yeah. That's why we're mixing our words.
RS, 1 in AVL, QR in 2-3 AVF. And so those 3 things are what we're going to use to find that left anterior fascicular block. In conjunction with the right bundle, that's badness in a patient that looks, it's that patient that looks like they're having a STEMI. And you look at the EKG, hey, no ST elevation, we're good. Yeah. Ooh,
wait a second.
Hold on.
Let me check these other things.
Oh my gosh, this looks like he's got that bifascicular block we talked about. Let's transmit this EKG and let's call
the hospital, talk to however your process works in your system, whether you have to call your med control, call the receiving facility, talk to a doctor, hey doc, this is what I'm seeing. And so I heard that this could be indicative of an OMI. What do you think? And if he says you're an idiot, yes sir. Well, and then later he comes back and the troponin, I guess I'm not an idiot after all.
I felt that way too as an ER doctor when I call that cardiologist in from home with a STEMI. Yeah. They get in the car. They're very good at coming, very supportive of me as an ER doctor and my patients.
But you guys transmit those. I mean, they see the 12 lead before they even.
Yeah, we have ways that we do it that are HIPAA compliant where we talk. We send these things to the cardiologist who's on his way to the hospital. Cath lab is activated.
Ready to go.
They don't question me. They just do it. Right. The problem happens when they get to the ER sometimes. The cardiologist looks at the EKG, and I've even had cardiologists get mad, and even in my opinion, rude. Yeah. Bless their hearts. I mean, they're just trying to do their job just like I'm trying to do my job.
Probably they're tired, 2 in the morning.
Who knows? Yeah, that's right. Yeah, So 2 in the morning, they look at the EKG, and it's, dang it, this isn't a STEMI,
Way to go,
called me in for this, and I'll explain, one of these lesions potentially, and they say, that's not ST elevation. We don't activate it based on these things. So the hospitals really need to look at the data and make these decisions in conjunction with the cardiologists, and they got to decide what to do. So these lesions are really important, and it's not just you that gets, the ER doctor complaining. As an ER doctor, the cardiologist will complain too sometimes, and I got to defend my patient. Right. So let's go to the third lesion.
Number 3,
Third lesion.
What's our third one?
All right, so the third lesion is the small hyperacute T waves. So in T waves that are out of proportion from the preceding R wave is concerning. So you're looking, let's just say you're looking at the inferior leads again, 2-3 AVF, and you're looking at that R wave and the T wave is taller. That's concerning, highly suggestive of a heart attack or an occlusive lesion of the coronary system on the right coronary artery.
Right.
So again, just to beat this home, you're looking at those inferior leads, no ST elevation.
Right. But
nothing. But
you see
hyperacute small hyperacute T waves. What that means is the T wave is taller than that preceding R complex.
So when you say, and we talked about this beforehand, when you say hyperacute, how is hyperacute different from a peak T wave, which we would typically look for a hyperkalemic patient? And not just look at that and go, oh, maybe their potassium is a little out of whack, and that's why they're having these peak T waves.
Good question. So the subtleties here with the relatively small peak wave, you're not going to see a lot of this, but one of the things that's classic for a hyperkalemic T wave is its symmetry.
Okay.
Like a church steeple.
Right.
Whereas with the hyperacute T waves, there's some asymmetry there at the base, and it doesn't quite look normal. But I don't want you to get caught up on that with this one, in my opinion, because these are smaller, and you may lose some of that subtlety with it being symmetric or not symmetric.
Yeah.
But the point here, I think what I would focus on, again, I always like to think of us riding out together.
Yeah.
Which we've done in the past.
Yep.
And you and I are looking at an EKG, and we see that those T waves in 2-3 AVF are taller than the preceding R wave, and the patient looks gray like a STEMI.
And it's only in 2-3 AVF that you'll see this?
No, you can see it in other areas as well. The example that I gave is in the inferior leads. And some of the subtleties of this are, again, we're presenting information, Matt, and I think you'd agree with me. We got to research this, and we got the link provided. Again, please check it out for yourself.
Yep.
But that's really subtle, but really important.
Got it.
So that's the third lesion.
Got it.
Anything we should talk about more with that?
I don't think so.
Okay.
You said it's, typically 2-3 AVF, inferior leads, you'll see hyperacute T waves.
With or without reciprocal changes,
Correct.
ST elevation. So
these are just patterns. Remember.
That's right.
Keep saying that over and over again.
And any pattern, any of it, whether you're looking at one in AVL,
Should
the
raise a
lateral
red flag.
leads, or whatever it is, concerning. All right. So the fourth pattern now we're going to look for is, again, we've talked about this before. Looking at the EKG, you're looking at the patient. Patient looks terrible, and you're looking at this, and there's no star, STEMI.
Yeah.
Oh man, right? But then you look closer, and you see ST depression in V1 through V4 somewhere. Classically V2, I would say. And so what do we do with that one?
Your posterior.
Get the posterior, right? And
or 15 lead, some people call it
15 lead,
whatever.
right? So I think this is the learning point. This is something I didn't know, and I don't think we taught this either, but we did cover the posterior MI.
Yeah, we did with Dr. Guerra.
Exactly.
Yeah.
And remember, we take the EKG and we flip it, and then it shows up at what looks like ST elevation. If you haven't done that before, you should watch that lecture. It's a great lecture. Yeah. Take your EKG that shows V2. You see the V2 depression, ST depression. You're going to hold that up, flip it over, and look it up at the light, and you can see what looks like ST elevation, which is the key there. Yeah. But what was kind of interesting with this one was that even if the 15 lead or the posterior MI, even if it leads V7 through 9, those posterior leads
that you move to the back, right?
Even if they don't show ST elevation, because you had depression in leads V1 through 4 and none of it in V5 and 6, right? Yeah. That alone is highly suggestive of something blocking the coronary artery system.
Back to sneeze.
Bless you.
Thank you.
So sneezing has no association. It's like
Is it true that your heart stops every time you sneeze?
No.
Okay. You never heard that?
No. But I heard, I'm not going to say what I heard because never mind. I don't want to say something. Well, I guess it's all medical, right?
I don't know. We're on a podcast. Send it. What are you going to say?
A sneeze is 1/16 of an orgasm. I shouldn't have said that. I'm sorry. I don't know if that's true or not.
Well, we'll explore that.
Oh man, I shouldn't have said that.
Oh, that's funny.
From a medical, purely medical.
Well, if it's medical science, then we're allowed to say it. Okay.
But the sneezing actually is very traumatic to the body. the power and the force. No, seriously, you can really damage things.
Well, I've heard, like, I know people, and I'm sure you've seen this. We're getting way off topic, but it's kind of interesting. They'll hold in
That's what I'm
this
talking about.
and it's super.
I work
bad
with
for
the
you.
doctor that does that.
Okay.
I'm like, dude,
Don't do that.
Don't do that because I'm gonna have to cover for you.
You gotta let it out. Let it fly.
Let it go.
Yeah.
I mean, cover.
Well, of course, go do the Dracula.
Yeah, or grab a
Tissue or something.
Yeah, if I have a big sneeze and there's just nothing I can do, I'll just lift up my scrubs and sneeze into my chest hairs.
I was gonna say something.
Oh no! Don't do it. Don't do I already went down the wrong path. We got to get back on
All
track
right, let's
here.
get back. Let's get this back on the road. All right.
So I think the thing we learned here.
Posteriors.
Yeah. So when you see ST depression in leads, any of the leads in V1 through 4,
Right.
and leads 5 and 6 have to be normal.
Right.
And when you see that ST depression, immediately you should think, wow, this could be a STEMI.
Mm-hmm.
This could be that occlusive. No, I shouldn't say STEMI again. I'm falling that trap.
Yeah.
It doesn't matter.
It's an occlusive MI.
It's an occlusive MI. We got pathophysiology happening in the coronary artery system that's going to need reperfusion, right? It won't,
Potentially.
It won't show up as a STEMI, but just as dangerous potentially.
Yes.
And you flip the EKG, you can see the STEMI. And this is one of those patterns that I think most cardiologists are aware of that I think would be amenable to going to the cath lab.
Yeah.
And it's taught as such. But the thing that I think is different that most people don't know is that when you get that posterior, right, and,
Yeah,
and
the
you're
12,
waiting to
15
see
lead.
STEMI,
Yeah.
you may not see it, but that's
That's a
okay.
huge indicator. Yeah.
And we talked about the reason for this too. The heart isn't. I don't want to stay on my mic here. The heart is an anterior.
Do it on your own heart. Yeah.
The heart is an anterior structure, right?
It's
So the
super
leads are here,
Right.
because you want the leads as close as possible.
Right.
And so when you start putting leads around the back, now
gonna
you're
lose.
putting posterior, the thoracic cavity. Now the heart's further away. Remember we talked about that.
Distance, tissue, everything.
Yeah, so I think we have to be very careful. And so I'll be clear. When you get the posterior, the 15 lead,
Yep.
it may not show STEMI, but that doesn't mean it isn't.
Right.
It doesn't mean that it is not an occlusive MI.
Yeah.
So be
It's
wary.
good to get the 15 lead because, like you said, having that data, having that information to document that you have it.
Yep.
But again, it's not. If you don't have elevation, does not mean you're not dealing with a STEMI.
Yep.
So, like with all of these things, transmit it. Communicate with the physician, tell them what your thoughts are, and let
Yep.
them make the decision.
Yep.
But if you do that, you have, as a pre-hospital, as a paramedic, you have done your job.
Yep. That's the fourth one.
Yep.
So here's the last one, Matt. So this one we've been teaching this for years, you and I.
Mm-hmm.
And I know this is one of those patterns of really a proximal left coronary lesion. This is worse than the Widowmaker. I mean, this is bad. These are the ones that used to show up classically as cardiac arrest.
Yeah.
But we're getting there so quickly to these homes and getting them so quickly to the ER. We're actually finding these and getting them to the cath lab.
Yep.
So this is AVR elevation.
Yeah. Which we never used to look at AVR.
You
I
know-
didn't even look at AVR.
No.
Never have.
You know what we used to call AVR? The R. I mean, this is terrible. This is a term we should never use. Retard. The retard lead.
Really?
That's what in medical school. That's what we would call the R lead.
Really?
Because we didn't use it.
Yeah.
It was like, what is that for? And it doesn't. Anyway, that's not true at all. This R lead needs reperfusion.
There's a lot of things that AVR is used for now.
Yeah.
VTAC identification.
Yep, that's right.
And now we got another thing so
Yep.
it's actually a fairly important lead.
And I will say, I got to say that word. That's such a. I have friends.
Yeah, terrible
with,
word.
Friends with
Yes.
children with some disabilities,
Yes.
and we need to. Man, they're patients. They're just as valuable as anybody else that
Yeah.
we need to take care of. And sometimes we use words flippantly because maybe we've never known anybody.
Right. Which was not what you were doing.
No,
You were simply
no,
saying
no.
that's
just
what
the way.
was-
That was my attitude 20 years ago. I was an idiot.
Well, that's what was taught to you in school.
Yeah.
So.
But the reason we would say that though is because we didn't appreciate the significance of that lead.
Exactly.
So, and I think sometimes when we're ignorant of things,
Right.
we don't appreciate them. Just like with that population of kids or adults even with disabilities, they're a beautiful patient population that we can do a lot of good for. And sometimes we don't fully appreciate that population until we know it or have friends with it. Same thing with obesity, right?
Yep.
You know, we'll say some pretty nasty things for those patients that need a bariatric bed. You know what I'm talking about?
Yep.
They're beautiful patients in a tough patient population sometimes.
And we don't know. I think a lot of times we make judgments about why they got that way. We have no idea why they got that way. It might have been something they might have sustained an injury that prevented them from exercising. I mean, there's lots of different reasons.
And when you put those EKG leads on a patient like that, an obese patient, man, you got to be careful. There's so much tissue.
You got to really have good lead placement.
You really do. Yeah. So this last lesion, though, it's not just AVR elevation. It's
AVR elevation is what we're looking for.
Plus diffuse ST depression. Yes. If you see AVR elevation with diffuse ST depression,
meaning global. Yeah.
It doesn't have to be every single lead, but a lot of it. Yeah. And again, just to keep it simple, AVR elevation with diffuse ST depression, specifically those lateral leads.
Yeah. AVL 5-6.
But you'll see it everywhere, potentially. And that is highly suggestive of what's called a left proximal main lesion. So that left coronary artery at the base of it coming off of your aorta.
This is plugging your MIV coming into your...
So bad. This is beyond Widowmaker, right? So this is proximal to the Widowmaker. So anyway, that left circumflex and the left anterior descending branch off of the left main.
Yeah, this is the big daddy.
This is the big daddy.
Yeah.
So this will kill you if you don't get this quickly to the hospital.
Again, this is blocking your hydrant. If you're a firefighter, this is blocking your intake.
LDH.
Your 5-inch coming into your pump.
This is an LDH, right? The large diameter hose, is that what you'd say?
LDH, your MIV is your main intake valve. Yeah,
main intake. That's a new term I learned. I've been calling it LDH.
Well, no.
It's good.
LDH is the hose.
Yeah.
And then where you connect your LDH to the engine is your MIV.
Right. Yeah. So that's exactly what's going on here. And so if you see that, it's not going to show ST elevation on the EKG. You got to pick this up.
Right.
It's one of those lesions that won't meet STEMI criteria in many hospitals and many systems.
Just dismiss this, and meanwhile, your patient could very quickly
get ready to
cardiac arrest on you. Yeah.
So those are the 5 lesions, Matt. And I think, again, like we said earlier in part 1, I don't know if we stressed it in part 2, but I'm going to say it again. If you're listening to this and you didn't know it, you owe it to our community to spread the word. Forward this to people you know. Have them watch this podcast so we can educate people. We need to spread the word for these things. We need to get these medical directors to look at this, those training divisions to train this.
And you know what I think we're going to do is we're actually going to make, I don't know if you'd call it a cheat sheet, but we're actually going to make a sheet, and we'll put it on our website once we get it made and distribute it for free, that you guys can print out, laminate, whatever you want to do, and put it in the back of your ambulance. So that way,
I love it.
If you go on a call, chest pain call, you have a patient that looks, man, this guy doesn't look good.
Yeah.
And you run a 12 lead and you're not seeing any ST segment elevation, right? The classic stuff.
Let's do this.
You can pull this form out and go, wait a minute, let me look at these other 5 indicators.
That's a great idea.
So we will do that.
We could definitely do that.
We will create that. We'll get it on our website. We'll offer it for free.
Yes.
So that, because it's so important that we're not missing these.
We could call it, instead of STEMIs, we'll say can't miss EKG patterns.
Yeah, or OMI.
Yeah.
I mean, again, to reiterate, we've said it over and over again, and I think it's important because people are going to think like, oh, this is a new thing. No, it's not a new thing. We're still talking about heart attacks.
Yep.
We're talking about lack of blood flow to the heart muscle, right?
Yep.
The coronary arteries are being blocked. All of that is exactly the same.
Yep.
All this is saying is that you can't just use ST segment elevation to identify an MI. It's not just that. There's more than that.
Yep.
And these 5 things are those other things. And then on top of that, you also have, I think it's important to note, you have NSTEMIs. You have times, or there are times, when a patient will have no EKG changes, but still be having a heart attack.
Right.
Right? And that's why it's important as pre-hospital providers. We're looking for these EKG indicators, but it's not 100%. It's not definitive. If your patient looks like crap, if they're pale, diaphoretic, vomiting, complaining of crushing chest pains, or little grandma that just says, oh, I don't feel good, always keep that in your differential diagnosis. Like, are they having an MI? Is this a heart attack?
Well, MI is a good term.
MI is a good term. It's an appropriate term. It's not STEMI necessarily, but always keep that in the back of your mind. Always transmit your stuff. Communicate your presentation to the physician if you think, hey, we might need to activate on this patient because of X, Y, Z. And these are 5 things that are new that not everybody might be familiar with.
Well said, Matt. Yeah, we got to, if we want to, our mission statement as educators, EMS educators, is to improve the health and wellness of our communities, right?
And we do that through education.
Yeah, if we don't know what to look for, we're going to hurt people.
100%.
We got to get this down. If you learn something new from these part 1 or part 2, you've spread the word, do the right thing. We don't stand to gain anything. We actually all stand to gain a whole lot in our community of education. But we need to get this word out. I'm seeing too many municipalities, too many hospital systems, too many agencies that aren't looking for these things.
Let's bring it home and even say you're at the fire station, because I've had this happen. We've had this happen in my department, where one of our members, I'm not feeling really good. I got some pain in my chest. Or, maybe they're at the station or whatever, and they run to this, hey, let's run a 12 lead on this patient. Let's see what they're doing,
Yeah.
You run a 12 lead on one of your own, one of our own,
Yeah.
right? Our brothers, our sisters.
Yeah.
And you run that 12 lead, and you're like, no STEMI.
No STEMI, it's normal.
We're good. You're good to go, whatever. And then they're like, okay, yeah, it must be just some indigestion or angina or something, and they go back to work. Yeah. And then 2 hours later, they're dead on the floor. Yeah. Because we didn't look, and we missed that they've got elevation in AVR with diffuse depression. Yeah. We missed that. This is super important for us to.
And I don't mean
it's just as important as looking for STEMIs.
I don't mean to complicate things, but we also have to appreciate the fact that, and I've had many patients like this before, is that you think a patient's having a STEMI by looking at them. They're nice and gray with chest pain, and then the EKG doesn't show anything.
Right.
And sometimes it's legitimately not a STEMI that's causing the symptoms. An aortic, maybe an aneurysm or an aortic dissection.
There's different reasons.
Pericardial tamponade. Who knows? A pneumo. There's a lot of stuff out there that's emergent and life-threatening that's not occlusive coronary pathophysiology that you can't get in the back of an ambulance, right? In addition to being very careful with the EKG, and if you don't see STEMI, be curious.
Yeah.
And like we've talked about in our lecture, check the pulses. Are the pulses symmetric? Could this be a dissection?
Look at your pulse pressures. What do those look like?
Really good lung exam. Yeah. Listen to the heart. Do you hear muffled heart sounds with distended neck veins? Did this patient was he in a car accident with chest trauma?
Good history. Good.
Right.
Yes, exactly.
There's a lot of good stuff. And this is what education is all about, is helping to equip you with the knowledge so you can take care of your patient.
Absolutely.
So that's why we're so passionate at what we do. And that's why we do what we do. That's why we sit here and work hard to try to educate people.
I always, and I think I've said this before, is we're kind of like medical detectives. Yeah. As paramedics, EMTs, paramedics, our job is to go in and ask the questions, and we go where the evidence leads us, right? Just like a detective on a case.
It's a good example.
Right? You're going where the evidence leads you. And so if you're doing good assessments, asking the right questions, doing the appropriate exams, looking at the findings and saying, okay, where is this taking me? Right? Don't make we always talk about, don't put the blinders on and think, this must be a heart attack, because you could miss something else. Right? So it's super important information. And again, we're going to do a whole CE hour on this. It might even be more than an hour.
And we're going to make that deliverable, the placard or something that people can put in their pocket or post on the wall or share with their friends.
Put on their phone. Yeah, we'll do
that. We'll get that done soon. But again, to close this out, what can our listeners do, our viewers do to help spread the word? I'm not a social media guru like you, so
I'm not a guru, but like our page. Or subscribe to our YouTube channel. Subscribe to if you're watching on Apple Podcasts or Spotify, like our podcast. That helps us. You can share that link with anybody that is a pre-hospital provider, physician, medical director, EMS person. Share that. This is all free that we do. We don't make any money off this. We are actually, real quick, we're working with CAPC to hopefully in the future you guys may be able to get actual CE credit for listening to these podcasts. So we're working on that as well.
I got to share one more thing. I think that's we've got thousands of students all over the country, you and I, and it's an honor to teach them. Mm-hmm. It's a high calling and a high responsibility and a weight that motivates you and I to stay up to date.
Right.
And so when you watch our CEs online and you subscribe to our stuff, we want to keep that cutting edge. Yep. We're always revisiting and learning, and we learn a lot with this cardiac pathophysiology. Yep. And so that's one of the benefits. I know it's one thing to watch CEs, but it's another thing to watch CEs that you know are up to date. It's so important.
Yep. See you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.